I'm so deeply honored today to be here giving the American Journal of Gastroenterology lecture. I am grateful to Dr. Spiegel and Lacey for inviting me to do this. They have a vision as the editors of the journal for propelling tremendous cutting-edge science forward while keeping the journal clinically relevant. And that's why I'm really honored today to talk about hepatitis C, where the science has really pushed forward a cure for our patients that really changed what we do every day in our clinics. So today I'll be talking about hepatitis C, the past, the present, and the future. So I'm going to take you down a quick walk, a stroll down memory lane of the past that we've gone through with hepatitis C. And this by no means is a comprehensive list of the individuals who were involved in the science behind this, but the discovery of the hepatitis C virus took some very important landmark times. In 1975, it was first recognized by Harvey Alter and others at the NIH that there was transfusion-associated hepatitis that was neither hepatitis A or hepatitis B. So they had tests for A and B, but it didn't register with any of those tests. And so just recognizing that there was some virus out there that wasn't A or B was really important. And in 1989, Michael Houghton and others published the first landmark paper isolating the molecular clone of hepatitis C, essentially identifying the virus. And then in 1997, very importantly, Charlie Rice and Dr. Bartenschlager also made a crucial development in hepatitis C in developing the replicon system. The replicon system is essentially hepatitis C virus in the lab. So therefore, you can then test against the virus in the lab different drug or therapeutic molecules that may work against the virus. And so that led to the direct-acting antivirals, boceprevir and telaprevir, with the first round of protease inhibitors. And then in 2005, Michael Sophia, while at Pharmasset, successfully found a nucleoside inhibitor called PS7977, which subsequently became sofosbuvir. And you might recognize Michael Sophia because the drug sofosbuvir is named after him. So in the discovery of the hepatitis C virus, we then, after it was discovered, go through a history of hepatitis C therapies. So starting in 1989 through 1992, we started trying interferon, we added ribavirin, we pegylated the interferon, and all of us sitting in this room went through those times of getting sustained virologic response rates that slowly climbed toward the 40 to 50% range. And then in around 2000, we started just sort of doing all sorts of badness. We went to everyday interferon, we treated for 18 months, we tried whatever we could, and it really didn't push SVR rates much beyond 50-some%. It wasn't until 2011 that the first generation of direct-acting antivirals, telaprevir and boceprevir, came out in 2011, that we really started to see the cascade of direct-acting antivirals that now push us into the above 90% range that we appreciate today. And what did we learn from the interferon era? We learned that when we treated patients and cured them, sustained virologic response, this was associated with reduced long-term risk of all-cause mortality. So this is a landmark paper published in JAMA in 2012 by Vandermeer, saying that all-cause mortality, if you achieved a cure for hepatitis C, was statistically better than in patients who did not achieve a cure. So we know that, and we learned that from the interferon era, that we needed to try to treat patients and cure them because they died not just of liver disease, but from all other causes as well. And this was confirmed in a large Taiwanese cohort study called the REVEAL study, REVEAL HCV, where they confirmed that all-cause mortality was reduced in patients who were able to achieve SVR, but also we saw reductions in liver cancer and reductions in extrahepatic diseases besides the liver. So the hepatitis C virus stimulates immune system changes and may cause other problems in other disease states such as the kidney, et cetera. So we saw this again and again in multiple studies that achieving SVR reduced all-cause mortality, liver cancer, and other diseases. But we learned some tough lessons from that era in the past. So the first DAAs, the telaprevir and boceprevir, in combination with interferon, when we did the clinical trials, we saw that we had serious adverse events that ranged from 5 to 12%. But when we took it out to the real world in the clinics, we saw serious adverse events jump to the 40 to 50% range. So this real world experience is something that will carry forward in liver disease as we go forward now into the present. We now expect that we want to see the same benefits or the same efficacy and the same results in the real world that we saw in the clinical trials, and that will be confirmed again and again in real world data. So that takes us to the present. Where are we now? Now we know that there are 95 to 100% of patients who get treated for hepatitis C can be cured. It's quite remarkable. We also expect to see real-world data to confirm that what we saw in these clinical trials that show these kind of numbers are true, and we hope and expect that even very difficult to treat patients can be treated with the direct-acting antivirals, not requiring interferon. So decompensated liver disease patients and even patients on dialysis in renal failure should hopefully experience the same benefits of direct-acting antivirals. So when we look at genotype 1, which is the most common genotype in the United States, the rates of cure are high across all regimens. So it really doesn't matter. You have multiple choices. You can see here if you use sofosbuvir and ledipasvir, if you use paritaprevir, ombidisvir, and desabuvir, if you use grazeprevir and elbasvir, if you choose any of these combinations and you do it according to the recommendation, the duration appropriate, you will reach above 90% for genotype 1. So that's really quite remarkable, since genotype 1 is really what we most commonly encounter in our clinics. And we can even reach 100%. So genotype 1b may be a little bit easier to treat than genotype 1a, and this is with the 3D combination. You can see across whether the patients were naive to therapy, what the race, where they geographically came from. In large studies, genotype 1b can reach almost 100% cure rates. Okay, so genotype 1, I think we have it in the bag. Regardless of which drug you choose, you will likely be able to achieve 95 to 100% sustained virologic response. But what lessons are we learning now from the real world? So we got burned the first time around, so now we want to make sure that those kind of data can be translated into our clinics. So the HCV Target study is a longitudinal observational study of 44 academic and 17 community medical centers across North America and Europe. So these are private practices, these are hospital-based practices, these are experienced clinicians. This is a broad range of clinicians treating hepatitis C. And importantly, the hepatitis C treatment decisions are made by the clinicians. So these are not protocol driven. These are clinical decisions made in the clinics every day. And the baseline characteristics of the patients are a smattering of everything that we would see walking into our clinics. We'd see some cirrhotic patients, some transplant patients, some HIV, a lot of naive patients. It would be exactly the kind of patient you would expect in your clinics. And I think, very thankfully, the real-world data that's been reported so far for ledipasvir and sofosbuvir in the Target trial, or Target study, showed overall SVR rates that are quite comparable to the large clinical trials. So we felt reassured that whether you received 8 weeks or 12 weeks or 24 weeks as a patient, you would expect to see the real-world benefit very similar to the clinical trials. However, a couple of things emerged from these real-world data. We found out that patients who have liver disease being treated for hepatitis C were using PPIs at a rate of 20 to 35%. So these are GI clinics, so it's not uncommon to see this type of PPI usage in patients, but 20 to 35% PPI use. And what we know is that some of the medications that are treated with that treat hepatitis C need acid for absorption. So solubility may be impacted if patients use acid-reducing agents or PPIs. So if 20 to 35% of patients in the regular clinics are using PPIs, how did that impact the sustained virologic response in the real world? Well, the Target study showed that patients who received 8 or 12 weeks of sofosbuvir and ledipasvir, there was a delta of about 6%. 5% here. So 93 to 98%. So 93 is still pretty good, but if you really want to try to maximize your patient's chance of achieving a cure with hepatitis C therapy, you really want to assess whether your patient really needs those PPIs and whether they could be off or reduce their PPIs during their time that they're on hepatitis C therapies. And this is another real-world data called the TRIO study. This is a large, also real-world database started in New York, predictors of response by PPIs, and they achieved also 97% overall SVR. And they looked at PPI, the type of PPI, the dosing of PPI, the daily units of PPI, but most importantly, statistically, if patients were on PPIs twice a day, BID, you can see here that that impacted the patient's chance of achieving SVR. So once a day seemed to be okay if you need it, but twice a day you really want to be a little bit more careful, especially if you want to maximize the chance of achieving SVR. So those were real-world data that I think are important for you to apply to your practice in thinking, do your patients really need those PPIs during the time that they're on the therapy for hepatitis C? What about non-genotype 1? So I already showed you pretty good data on genotype 1, that's 95 to 100%. What about non-genotype 1? Well, pan-genotype treatment is here. So recently approved sofosbuvir and velpatasvir, which is an NS5B nuke, plus a very potent NS5A, which is pan-genotype, treating all genotypes across the board, 99% overall SVR. So whether you were genotype 2, 4, 5, or 6, these patients treated with this particular combination seem to have excellent overall SVR rates. So not only do we have genotype 1 in the bag, I think that we have all other genotypes in the bag as well. But I do want to spend a minute on genotype 3. So we used to lump, as you recall, genotype 2 and 3 together. We used to call them the easy ones to treat. But it turns out, as we learned more about genotype 3, those patients seem to have more steatosis, and they seem to have more rapid disease progression. So this is a study that looked at SVR, patients who achieved SVR versus patients who didn't, and the natural history of these patients in terms of their cumulative mortality. And you can see here that genotype 1 patients, the curve goes like this. Genotype 2, the mortality curve goes like this without achieving SVR. But genotype 3, the mortality curve is much higher if you are unable to achieve SVR. So it's actually very important for us to be able to successfully cure genotype 3 patients. And the last couple of years, we've had a little bit more difficulty with the direct-acting antivirals in terms of really penetrating or getting those high levels of SVR rates with genotype 3. But now with the new pan-genotype therapies that we have, we can see that even genotype 3, whether they're non-cirrhotic, treatment experienced, or cirrhotic, they are all pushing above 90%, except for, you can see, a treatment experienced, somebody who failed therapy in the past, and cirrhotic patient, their SVR is about 89%. So we really like to see this be pushed a little bit higher. So the consideration is, this is a 2-drug combination with sofosbuvir and velpatasvir. Perhaps genotype 3 patients who are treatment experienced and cirrhotic, these patients may need additional ribavirin. So ribavirin may be considered in this particularly difficult treatment group to try to get this 89% into the mid-90s where we'd like to see it. How about the toughest to treat groups? If we talk about decompensated liver disease, so these are patients who are child's class B patients, so these are patients who are cirrhotic and decompensated. Many of these patients, 75 to 83%, had ascites. 50 to 60% of these patients were encephalopathic. So these are the sickest of the sick liver patients. And what happens when we treat these patients with DAA therapies? We can see that overall, if you treat without ribavirin, you're getting 80-some%, and genotype 3, 50% SVRs. So even with very potent antiviral therapies, 2-drug antiviral therapies, we don't quite see, especially in genotype 3, the SVR rates that we would like to see. But once we added ribavirin in the clinical trials, there was a ribavirin arm for 12 weeks. You can see that that then pushes sustained virologic response rates in almost every group to 95% or better, except for the genotype 3 patients. So even with ribavirin, we still have a little bit of opportunity in the decompensated cirrhotic patient who's genotype 3 to move a little bit in regards to potential future options. If you treat somebody who has decompensated liver disease, what happens to them? The Astral 4 looked at child Pew score improvements, and we saw improvements in albumin and bilirubin in these patients following a course of therapy. Most patients showed improvement in their albumin and their bilirubin, and MELD score improvements as well. So if you can catch the patients early enough, perhaps some of these patients will be rescued from requiring liver transplant, which is already, as it is, a scarce resource because we have a stagnant number of organs available in terms of donor organs for liver transplant. So if we can save these patients from liver transplant by treating their hepatitis C, we expect to see the numbers of hepatitis C patients decline over the next decade. And the question is, if you have somebody who has cirrhosis and portal hypertension, does curing them decrease their portal hypertension? So this study of 104 patients published this month showed that in 104 patients who had hepatic venous pressure gradient of over 6, so they had portal hypertension. If they had borderline portal hypertension of 6 to 9 millimeters of mercury, there was no progression of their disease, and 63% of them had reduction in their portal pressures. If they had a little bit more portal hypertension with gradients of over 10, they still had a decrease of 10% in most patients, but the Child's Pew B patients were less likely to have significant portal hypertension reduction. So the earlier we catch them in their clinical development of portal hypertension, the better their chance of being able to reduce the portal hypertension, reduce their chance of bleeding from GI bleeding from portal hypertension, and all of the complications such as ascites, etc. And then one last group that used to be difficult to treat. So sofosbuvir is metabolized through the kidney. So you can't use sofosbuvir-based therapy. It's not recommended to use sofosbuvir-based therapy in patients who have end-stage renal disease or on dialysis. So we were a little bit limited because we knew that dialysis patients had a higher percentage or prevalence of hepatitis C infection. So this randomized double-blind double-blind study of treatment-naive and treatment-experienced patients who are genotype 1 were treated with elbasvir and grazeprevir for 12 weeks. Elbasvir and grazeprevir is metabolized through the liver and not through the kidneys, and the overall SVR rate in patients who had end-stage renal disease was 94%. And even in patients who are on dialysis, it was 93%. And if you actually exclude 6 patients who dropped out for non-virologic reasons, the overall SVR rate was 99%. So even in patients who are on dialysis, and these are usually quite sick patients, they can tolerate direct-acting antiviral therapy with excellent sustained virologic response rates. The question we always get asked is about resistance. So you're hearing a lot about that in the academic world, about resistance. And the reality is that for your clinical practice, if you choose or if you use good direct-acting antivirals, you can overcome resistance. So we saw from the ASTRO-1 study looking at sofosbuvir and valpattosvir, even if you had baseline resistance mutations, 42% of people had baseline resistance mutations, their overall SVR was 99%. So if the question to me today is, do you need to do baseline resistance testing before you treat somebody to know if they have resistance mutations? My answer would be no, not in most cases, because you will achieve SVR even if you have baseline resistance testing, if you have good, solid, direct-acting antiviral therapy. There is one exception to this. If you have a genotype 1A patient and they do have baseline resistance testing that shows that they have resistance, and you're treating with elbasvir and grazeprevir, they have a reduced SVR rate down to 70% unless you extend therapy and increase the duration to 16 weeks. So you can overcome resistance in everyone. You just have to use the drugs appropriately, but pretty much everyone can overcome resistance even if you have it at baseline. So we moved from the present, which I think is pretty great, to the future. What does the future hold for hepatitis C? So DAA therapies and how they may affect liver cancer, I think is an important question. How they may affect hepatitis B, the rising acute hepatitis C population, salvage regimens. So a lot of people ask me, what are you doing when patients, if you have a 5% relapse rate, that means 1 in 20 patients are going to fail therapy. What will we do with those patients? And I have some preliminary answers for you. And then refining therapy for the future to try to make it easier and shorter as possible. So a year ago, I spoke at ACG in Hawaii, and I said that I had discussed that there were a couple of cases that I was seeing of reactivation hepatitis B. And this year, it's changed significantly. What we know is that when you have hepatitis C infection, it stimulates interferon stimulating genes. So your body naturally produces some interferon when you have hepatitis C. It just doesn't produce enough to clear the hepatitis C. So when you produce interferon then suppresses the hepatitis B virus, right? So if you treat the hepatitis C, DAA therapy causes an immediate decline in the hepatitis C virus. Then the interferon gamma-induced proteins, IP10 levels, drop 49% after 1 week. So suddenly you have a drop in your immune system, and what happens? The hepatitis B can start to flare. And so we have seen now 24 case reports. The FDA has seen 24 reports of hepatitis B flares. As soon as the virus comes down, the hepatitis B virus goes up and can cause a clinical flare, and severe viremia and hepatitis have been reported developed in patients who receive hepatitis C and direct-acting antiviral therapy. So in October, a couple of weeks ago, the FDA issued a boxed warning on all DAAs to say that patients with hepatitis C who are being treated need to be checked for hepatitis B, because 2 patients have now either required liver transplant or died due to hepatitis B reactivation. And a very interesting couple of studies have come out about the same idea. If you have immunologic change when you get rid of the hepatitis C, does that sometimes increase the risk of liver cancer development? So this study, 344 cirrhotic patients who were treated with DAA therapies and followed for 24 weeks after, so only 6 months after being treated for hepatitis C, they achieved an SVR of 91%, but they found liver cancer in 7.6% of those patients, 28% in those who had a previous cancer that had been treated, and 3% in those with no history of liver cancer. So this is much higher than what we would have expected based on the natural history and based on the cancer detection rates previously when we had treated with interferon-based therapies. So multivariate analysis in this study suggested that child Pew score and prior liver cancer were risk factors for aggressive liver cancer recurrence post-DAA therapy. So this is very controversial. I would say that this is very relatively early in this understanding of this potential phenomenon, but I think that from your standpoint, from a clinician's standpoint, if you have a patient who has hepatitis C that you're treating, you need to make sure that you check them for hepatitis B, and you need to make sure to follow them for liver cancer, especially if they already have any degree of significant fibrosis, and certainly if they have a previous history of liver cancer. So what else is happening in the future? The future will hold new hepatitis C patients, because even though we're curing patients right and left, we're seeing an acute incidence of a rise in the incidence of acute hepatitis C. And this is CDC data over the past decade. And you can see here that the age group from 20 to 40 has had a marked rise in acute hepatitis C. And the reason for this can be mainly explained by the opioid and heroin epidemic that's occurring in the United States in young individuals. We are going to see these patients coming into our clinics with acute hepatitis C or jaundice or abnormal liver enzymes, and you have to be aware that these are the patients that are now being diagnosed with acute hepatitis C. So what should we do about acute hepatitis C? I think for the most part, you want to wait a little bit and see if they clear, because 15 to 50% of patients who have acute hepatitis C will clear. So if you wait 12 weeks and they don't clear, then you want to think about treating them. We have some limited data on the treatment of acute hepatitis C. So this is a study that looked at sofosbuvir and ledipasvir, so 2 DAA therapies, and sofosbuvir and simipavir. So those patients were treated for either 4 weeks with soft lead, or they were treated for 8 weeks with soft sim-soft, and both arms achieved 100% SVR. So if you treat acute hepatitis C, first of all, you might wait a little while to see if they clear on their own, but if you elect to treat, the preliminary data suggests that they may have very good outcomes with early and shorter therapy. But I think, again, this is very early to determine this and needs to be replicated, but these patients seem to do quite well with DAA therapy. But I think we're going to be faced with patients who are people who inject drugs. So PWIDs is the term for people who inject drugs. And if you, these are the people who are transmitting hepatitis C. And so the question is, should we occasionally, or should we be thinking about treating these patients to prevent further transmission, et cetera? So DAAs in PWIDs was looked at in one study here of 12 weeks of grazeprevir and elbasvir in patients who are on opioid replacement therapy. So methadone or other types of opioid replacement therapies. And unfortunately, even though they were on those therapies, 61% of them had baseline urine tests that were positive for drugs. So they were using various amphetamines, barbiturates, et cetera. Despite being on drugs, so those who had a positive baseline drug screen versus a negative baseline drug screen, they still did pretty well. And there was a 96% adherence rate. So it may be controversial whether we should be treating patients who are actively using drugs or not, but the idea or the concept that they can still respond to therapy well, and if they are adherent to medication, will have a good outcome. Maybe we can decrease transmission rates of hepatitis C if we are more open to treating patients who inject drugs. So I think the burning question for most clinicians today is about salvage therapies. So if I'm talking about 95 or 99% success rates and you treat enough patients, you're going to have one or two patients in your practice, most people, who have relapsed to really good current therapies. And what should we do? So if you're tempted to retreat with longer therapy, the same therapy but longer, I would caution you, because this is a study that was presented by Eric Lawitz, who looked at retreatment with the same treatment, but 24 weeks. And overall SVR rates were 71% for patients who were retreated with the same thing that they had the first time. And if they had a shorter therapy, 8 weeks of treatment, and they got retreated, the SVR rate was 80%. And if they got 12 weeks of good therapy and you retreated them with 24 weeks, your expected SVR was 46%. So I don't think that's sufficient, and I think this is an expensive experiment to do for your patients, to retreat them with the same thing that they already failed with before. And I think that we should wait until data emerges on retreating them with something different. Because not only do they fail therapy, 30 or 40% of the time, patients who were retreated and failed therapy had emergence of an NS5B variant. So they were more resistant and perhaps were going to develop resistance that would burn the bridge to future therapies down the line. So I would caution you today about retreating with the same thing that they got treated with the first time and just doing longer therapy. I don't think that is a scientifically sound endeavor for most patients. So because I feel like coming very soon is salvage therapy that I think may be a better option for most of our patients. So DAA salvage therapy is a triple combination. So they're a drug called sofosbuvir, which you know, velpatasvir, which is a second generation NS5A inhibitor with better resistance profile, and avoxaprevir, which is the new protease inhibitor. So a triple combination in patients who failed therapy the first time. So this is the study design of the phase 2 study, treated for 12 weeks in a multi-center open label study. Broad inclusion criteria. So if they were genotype 1, they were exposed to NS5As or more than 2 DAA classes. If they were genotypes 2 through 6, they would have had PEG, ribo, or any DAA, and 50% of these patients had compensated cirrhosis. So this is triple therapy for patients who have been exposed to previous DAA therapy, and the salvage regimen worked very well. So you can see here the 99% overall SVR rate. Genotype 1, 2, 3, and 4 through 6 had excellent SVR rates in the salvage regimen. So that's why I would caution you today to wait a little bit. I think we're going to have data on the phase 3 studies very soon, and I think it's going to be, I'm hopefully very optimistic based on this phase 2 data. And the resistance analysis from this data suggests that even if they had baseline resistance-associated variants, so these are people who were previously treated and now have resistance, this triple combination still yielded an SVR of 99%, even with resistance seen in a large proportion of these patients, okay? So I think you're gonna need stronger than just 2 drugs, at least you'll need 3 drugs, but there are some potential other options. There's a dual drug regimen that is being studied right now for salvage. This is the Abbott 493 and Abbott 530, which is a pan-genotype PI, protease inhibitor, and a pan-genotype NS5A. This is the Magellan study looking at genotype 1 patients who failed previous therapy with good NS5A and sofosbuvir-based therapy. So these are patients that got good first generation or good first round DAA therapy. And the Abbott 530 has very good EC50 profile in terms of retention of antiviral activity even against the common mutations. So the Q30, the L31, the Y93, this seemed to be probably one of the most potent in vitro NS5As that even retain potency against the mutations. And the patients in this study who got exposed, they got exposed to sofosbuvir ledipasvir, they got exposed to Simsoft, they got exposed to a variety of DAA combinations. And if you look at the modified intention to treat, also with a dual drug combination, 95 to 100% SVR. So some of these patients were lost to follow-up, and if you remove those patients, that's the modified intention to treat. They had a 95 to 100% SVR. So whether it's a 3-drug combination or a 2-drug, very potent combination, the salvage regimens for patients who've been exposed to the current DAA failures or the current relapsers that you have in your practice, there will be, I think, rescue therapies coming very soon. But if you're one of those people that really needs to do something right now and you just can't wait, there is a little bit of data to give you some background. This is the C-SWIFT retreatment using what we have today. If you were to cobble together what we have today and try to put together your own 3-drug combination, this is a 25 per patient study that looked at elbasvir, grazeprevir, which is what we have available now, plus sofosbuvir, which we have available now, plus ribavirin. So if you want to really do something today, and you want to look at the available data, this is a 25 patient study looking at this combination, elbasvir, grazeprevir, plus sofosbuvir, plus ribavirin, you can see that the overall SVR was 100%. So only 25 patients, so don't run out and get too excited about doing this, and this would be a very expensive combination. But if you feel like you had to do something and try to put it together today versus waiting for the available data and therapies in the coming months, this is what you might consider doing. So the modified full analysis looked at saw 100% SVR, whether they were prior treated for 4 to 8 weeks, or they had baseline resistance, or they were cirrhotic. They seemed to do well with this really triple plus ribavirin combination. What else is cool that's coming in the future? Well, I'm not really sure that this is going to pan out for everybody, but there was a study that looked at ultra-rapid virologic response. So get this, 26 patients, all genotype 1b. This is a Chinese study done in China. They took 3 drugs, and they put these 26 patients on 3 drugs, 3 good drugs, and there are various combinations of drugs here. They tested the virus at 2 days. 2 days into antiviral therapy, and if the patient was negative at day 2 of treatment, so an ultra-rapid virologic response, they then got only 3 weeks of treatment. So out of the 26 patients that were treated, 18 of them were negative at day 2. That's 69% of them achieved an ultra-rapid virologic response. Those patients were subsequently treated for 3 weeks and achieved 100% SVR. So 3 weeks of therapy in a very selected genotype 1b Asian population, maybe we can start to really save some money by doing this. But I think, again, that might be a little bit difficult, and I'm not sure that this is going to pan out for most patients, but a very interesting concept of ultra-rapid virologic response. But I think more realistically, we will be able to shorten therapy to 8 weeks. So the ABT 493 and 530 combination was looked at for 8 weeks in treatment-naive, non-cirrhotic genotype 3. So remember that genotype 3 is the hardest to treat genotype, and they achieved a 97 to 100% SVR with no virologic failure. So 1 patient withdrew consent. So even in genotype 3, a very potent 2-drug combination may get us to 8 weeks for everyone. And this is even seen in cirrhotic patients. So naive genotype 3 cirrhotic patients treated with the same 2-drug combination, 100%. So I think that more realistic than the 3-week treatment, I think 8 weeks for all patients, I think is a very strong potential coming up in the next year. So in conclusion, I think that we can say the past has been rocky but fruitful for us. We have learned a lot from the lessons of interferon. We learned that all-cause mortality is reduced with hepatitis C therapy. I think the present is pretty great. I've showed you data that all genotypes can be cured at high rates. Some patients may still need a little bit of ribavirin with the current therapies that we have now. Genotype 3 cirrhotic patients who are treatment experienced might need ribavirin, and and the decompensated genotype 3 patients may also need ribavirin. But the future, I think, is extremely optimistic and positive. We see data on retreatment for your 1 or 2 patients you have in your practice that are relapsing to therapy. Retreatment strategies are coming for those patients, so be patient. I showed you a little bit of data that looks very positive. I think shorter therapies may be possible for all patients, so we're going to just keep pushing the boundaries of where the shortest therapy that we can go, but it looks like 8 weeks seems to be pretty positive. And I think we have to recognize and be aware you will see more patients in your practice over the next years with acute hepatitis C. And so I think we're going to see more data on how long we should wait and what we should treat with for hepatitis C in this younger population that you will be seeing more often with hepatitis C. Thank you very much.